Welcome to the post-row landscape implications at the intersection of health, rights, and justice seminar. Good morning, everyone. Thank you for being here. We have folks in the room with us, but we have quite a few folks online. Welcome back to those of you who have attended our seminars before, and a super special welcome for students who are attending the first time. Welcome to our seminar. People are still coming in, and I'll remind you again that there's food. You can get it at any point. So I hope that you'll find a lot of value in our seminars and have thoughtful questions for our speakers at the end. This is our first Heilbrunn Department of Population and Family Health Seminar of the year. And we're lucky to have brilliant panelists, Professor Stephanie Grilo, Professors Kelli Hall, and Professor Goleen Samari, all of whom teach here in PopFam. My name's Terry McGovern. I'm extremely proud to be the chair of this department and the director of the program on global health, justice, and governance. I think you all know this, but in case you don't, in this department, we focus on health and human rights, sexual and reproductive justice, the health of forced migrants, environmental health and justice, and global health, justice, and governance, and a whole range of issues within those broad categories. A bit about me: before my time at Mailman, I was a lawyer and founder of the HIV Law Project. I did lots of litigation related to structural barriers and discrimination, along the lines of much of what we'll discuss today. My work now focuses on disrupting structural barriers to reproductive and environmental justice, and sadly, responding to and analyzing the current public health crisis of abortion bans and criminalization. I'm really thrilled to give a brief introduction to our panelists today. I'm very honored to get to work with such incredible faculty, and I'm particularly happy to be with them to discuss this issue today. Dr. Stephanie Grilo is an assistant professor in our department. She's a social scientist and public health researcher. She focuses on adolescent health globally and domestically, and emphasizes the need for taking a resiliency approach to improving health outcomes for vulnerable populations. What does this mean? It means work on understanding multiracial identity formation and the influence on health outcomes, adolescent preventive services, comprehensive sexual health education, and its role in preventing sexual assault, pregnancy outcomes for young women of color, and global research on fertility decision-making in areas of HIV prevalence, high HIV prevalence. Dr. Grilo co-teaches qualitative methods in the core, as well as in population and family health. She's the co-founder of Mosaic, Mentoring of Students and Igniting Community, a faculty and student mentorship community for first generation and students of color in the department and in the school more broadly. And next to her is Dr. Kelli Hall, who's an associate professor in our department, a social epidemiologist and advanced practice nurse. Dr. Hall's research focuses on the social and structural determinants of maternal, child, and reproductive health in the US and globally. She studies the effects of poverty, policy, racism, health systems, and toxic social stress on disparities in maternal mental health, morbidity, and mortality, and the role of community-driven solutions, multi-level interventions, and integrated models of care. She has served on Society for Family Planning Board of Directors, National Medical Committee of Planned Parenthood Federation of America, APHA's Population, Sexual, and Reproductive Health Leadership, and as part of the PI at the Center for Reproductive Health Research in the Southeast at Emory University. She is the founding co-director of Mailman's Office for Community Health Equity Collaboratives and on CUIMC's Anti-Racism Task Force. She's the National Academy of Medicine Emerging Leader. I hope you're actually absorbing all these things that I'm saying, because they actually represent a deconstruction of everything that's been wrong, I think, with some of our responses to a lot of the health crises we're describing. So what my colleagues here are doing is infiltrating and deconstructing things that really do need to be infiltrated and deconstructed in lots of different categories. So just to note that, even though I'm saying a lot of big words. Last but of course not least is Dr. Goleen Samari, who is an assistant professor in our department. She is a population health demographer whose research focuses on social inequities in health. She examines how racism, gender inequities, and migration-based inequities shape population and reproductive health domestically and globally. Her research remains focused on addressing intersectional structural determinants of health. She focuses on issues related to immigrant health and sexual and reproductive health and rights. She is recognized as a thought leader on the population and reproductive health effects of discrimination for Muslim, Middle Eastern, and migrant communities, and has received numerous notable honors for her contributions to health equity research. So you can see why I am so honored to get to work with all these three faculty members.
It's all ours.
So I'm going to just do some brief opening remarks on the recent reversal of Roe versus Wade. As you well know, a highly extremist Supreme Court officially overturned Roe on June 24th in Dobbs v. Jackson Women's Health Organization, ruling 6-3 that abortion is not a protected right under the Constitution. I kind of feel like I don't remember much since that date, except that it's been very busy and very upsetting. And it's a dream that we don't seem to wake up from. So just to acknowledge the kind of trauma that that decision imposed on us, we went from working to actually reduce all of the factors of why people are pregnant and don't want to be, to reacting to an extremist criminalizing decision. So even before the official ruling, we knew that this was a likely turnout. In May, we published a letter in the Washington Post urging the Supreme Court to uphold Roe v. Wade. We got 26 deans of public health to sign the letter, and I'm proud to say that our dean, led that effort to get deans to publish that in the Washington Post. So we were anticipating this and trying to organize the public health community to respond proactively. We know that this reversal is already having devastating effects on women and birthing people, particularly people of color, members of the LGBTQ plus community, low-income people. This is going to be discussed in greater depth, but we know limiting access to abortion leads to poor maternal health outcomes. And we know also states with more abortion restrictions have higher rates of maternal and infant mortality. One of the things that has most upset me that I think is finally shifting is the lack of attention to the fact that these states do nothing to protect the health of mothers and children. They lead in every category as having horrible health outcomes. So the hypocrisy of focusing on this particular issue in the ways that they have cannot be overstated. A nationwide total ban of abortion could increase pregnancy-related deaths up to 21% overall, 33% for Black women. Everything, I just came from teaching my environmental justice class, and everything is connected to everything. We know that in the context of people's lives, climate change, pollution, racism, all of it is connected to reproductive justice and the fact that abortion is now illegal in 11 states. 1 in 3 women between the ages of 15 and 44 now live in a state where abortion is completely banned or mostly banned. We know millions of people will have to travel long distances to access healthcare. We're seeing lots of states that protect abortion rights with incredible influxes of patients from other areas. State law currently protects abortion in 21 states and DC, but is actually at risk of being severely limited or prohibited in 26 states in total. So as we know, there's a criminalization trend, which our speakers will get into in more detail, that our department is very involved in. We know low-income people and people of color have always been arrested and prosecuted for miscarriages, stillbirths, or attempting to end a pregnancy. basically the reversal of Roe and allowing the Texas law to take effect, Texas SB 8, has unleashed this kind of move towards criminalization, encouraging citizens to report their neighbors, be eligible for a cash reward if they successfully sue someone for obtaining an abortion. In Mississippi now, anyone performing or attempting to perform an abortion can be charged with a felony or up to 10 years in prison. In Alabama, performing an abortion at any stage of pregnancy is a Class A felony, punishable by 10 to 99 years or life in prison. There's growing concern about the role of HIPAA. I was attending a meeting of prosecutors who were talking about there needs to be evidence for a prosecution. So the role of HIPAA protecting people's reproductive health data from state laws enforcing criminalization is quite serious. The federal law provides the floor by which states cannot go below. They can give additional protection, but they can't go below what HIPAA says. So actually making sure that HIPAA is as protective as possible of reproductive health information has become critical. If any of you read the New York Times article, you know that doctors in a lot of states are trying to figure out how to make decisions that they're not going to make them lose their licenses. You have people in small clinics in rural areas this has all been playing out for 2 months, confused about what they have to hand over, what they don't have to hand over. In places like CUIMC, we have a very strict policy that we will not share medical records without a subpoena, but there's a lot of language in HIPAA that needs to be interrogated and rethought to make sure that we're not, disrupting medical care and in effect releasing medical information to authorities. I just want to point out a poignant moment in this prosecutor meeting where the prosecutors were saying, we get it, abortion is about bodily autonomy and we shouldn't just be focusing on rape and incest and abuse, but in fact we see in many cases every week of children who have been sexually assaulted. And we're now faced with the situation where we're looking to prosecute the perpetrator of that at the same time as we're being asked to prosecute potentially the people who've helped her. So I just want people to focus on the real lives at stake here and what's happening, not just to people who may be pregnant and don't want to be pregnant, but also the network of providers who are now at risk of losing their livelihoods and frankly of incarceration in some places. So this couldn't be more serious and more upsetting. We're injecting criminalization into an area that is fraught with lots of complexities. And it's really, really not okay, to put it in the vernacular. So we are really involved in all of this and conducting research on a lot of different aspects, including who elects the prosecutors and who elects, the local officials who make decisions about criminalization, et cetera. But just to say, we're thrilled that you're all here because we all need to actually pitch in because this is quite serious. With that, I am going to start with turning things over to Dr. Grilo, who will share her findings from her work on Title 10 and the implications of overturning Roe for sexual health and family planning.
Thanks, Terry, and thanks everybody for being here. I could not agree more that I think one of the reasons this is so important is that we need to all come together and brainstorm sort of how to push back on all of what Terry said, all of what I'm going to say, and all of what Kelli and Goleen are going to talk about as well. So thank you for being part of that conversation. I'm going to start off today by really just talking a little bit about our research on Title 10, what Title 10 is, what the gag rule is. And although it's a little bit tangential to the overturning of Roe v. Wade, I hope what you'll see is that this sort of politicization of reproductive rights is not new, which I think we all know. And it's really been going on for decades, well before the overturning of Roe v. Wade. So a little bit about Title 10, which I'm sure some of you could tell us, but Title 10, for those of you who are less familiar, is in the United States, the only federal grant program with the exclusive focus of providing family planning and related preventive health services. And since it was started, which was in 1970, it really has become the major funder of contraceptive services for low-income people in the United States. And it really has played an important role in the sort of social safety net in the healthcare system in this country. And I think that's what our work on Title X really tried to look at, which was not just Title X, but sort of the layering of multiple policies that really erodes that social safety net that exists for people. So 2/3 of Title X clients have incomes at or below the federal poverty level, and nearly 40% are uninsured. And when you look at sort of the access to the healthcare system in general for people who access Title X services, in 2016 alone, 60% of people who received contraceptive services at a Title X clinic had no other interaction with the medical system that year. So that just sort of shows you that this really was an entry point for people into the into the healthcare system. And when that's taken away, yes, it affects their contraceptive services, which is critically important for people, but it also affects just their ability to access the healthcare system in general. So what's the gag rule? In the Trump administration, in March 2019, issued a new final rule for Title X, and it has become known as the gag rule because it essentially said that there's a prohibition against using Title X funds to refer for abortion as a method of family planning, or to perform, promote, or support abortion as a method of family planning. So essentially, you could not talk about abortion, you couldn't present it as an option, you couldn't refer clients for abortion if you were going to accept Title X funding. It also required some infrastructure changes that became essentially impossible for clinics to incorporate. So it said that they had to maintain physical and financial separation from locations which provide abortion. So you couldn't have one building where half of it provided abortion and half accepted Title X fundings, for example. And this change reversed prior regulations that allowed a grantee's abortion services and Title X services to share common staff, facilities, and medical record systems. So it sort of erased that ability to be at all connected. So many abortion providers and affiliates were unable to comply with those regulations because they were presented with such sort of harsh rules. And so we're essentially forced to withdraw from Title X and no longer receive that funding. So our work, both qualitative and quantitative, but I'm going to focus on the qualitative findings today, really tried to understand what the effects of that gag rule was in 3 different states. So we looked at Maine, Wisconsin, and North Carolina. So my findings will focus a little bit more on those 3 states, recognizing that we picked those states because they were geographically distinct, politically they were distinct. And so we wanted to sort of understand what happens in these 3 very different states and what can that tell us about sort of what's happening in the United States more broadly. And really to understand sort of how the healthcare system was affected. We spoke to both community-based organization leaders and also clinical organizations and clinicians about sort of what these Title X changes and what this broader reproductive rights landscape really meant for the social safety net for their clientele. And we wanted to understand, like Terry said, everything is interconnected, right? So we wanted to understand not only sort of the direct effects on contraceptive services, but really on socioeconomic, political trends that threaten sexual and reproductive health, rights, and justice, often for already marginalized communities. So just a little bit of background on what happened in Maine, Wisconsin, and North Carolina, specifically with Title X. So in Maine, the single Title X grantee withdrew in August 2019 after participating in Title X for nearly 50 years, leaving the state with no Title X funded health facilities. In Wisconsin, 17 of the state's 59 Title X funded sites withdrew from the program, and these losses contributed to over an 80% reduction in the number of female contraceptive patients served by Title X in Wisconsin. And in North Carolina, Planned Parenthood affiliates were stripped of federal funding in May 2019, and the North Carolina Department of Health and Human Services became the state's sole Title X grantee. So by continuing to accept those funds, the state health department could only provide Title X subgrantee funding to clinics that, again, did not counsel for or refer for abortion services. So there's a lot I could sort of touch on today, but I sort of focused on the politicization of reproductive rights, this layering effect of multiple policies, and then again, how all of these states are interconnected and that these ripple effects are incredibly evident. And really that's what all of the people that we spoke to, both clinicians and community-based organizations, talking about sort of how all of these policies and this just overall climate affects people really at every possible level. So Terry mentioned this before, but it's become clear in the United States that reproductive health care has been subjected to politicized attacks, partisan policy shifts. We'll talk about this more, but in 2019, 17 states enacted legislation limiting access to abortion, and this was before Roe v. Wade was even overturned. And these laws are all sort of intersecting with other factors that are affecting the health and well-being, both at the state and the federal level. So there's other policies that are sort of happening and compounding these effects at the same time, right? So there's Medicaid cuts, there's the truly lack of available comprehensive sex education, which Dr. Santelli could talk about for hours. There's increased funding for crisis pregnancy centers, which we all know are a sham. And then there's also the sort of added difficulties of the COVID-19 pandemic, right? That is already limiting people's access to safe healthcare, or making them nervous to enter clinics, or making clinics overstretched and overburdened and unable to provide care, right? So we have to think about these things as not just in sort of silos of like, this is reproductive health, and this is some other type of health, and this is mental health. Like, all of these things are interconnected. And another thing that's important, I think, to understand is that even though the gag rule was reversed by the Biden administration when Biden took office, the sort of yo-yoing of policies back and forth, and the need to constantly be responding, reconfiguring, deciding if they're going to take funds, like these things takes months and years of planning for clinics to be able to do. And so just because the policy is reversed doesn't mean all of the harm that was put into place by the gag rule that Trump put in, it doesn't just go away, right? It takes months and years of planning to sort of set that back up. And it also takes months and years and decades to regain trust with communities, right? So if you tell people we no longer serve your community because of X, Y, and Z, and then a year later you say, oh, actually we do, right? Like, that's confusing, and it doesn't really make any trust between people and providers. In terms of the layering of policies and restrictive policies, North Carolina, for example, has really had an increasingly conservative political landscape that's led to several pieces of legislation that have limited abortion access. So between 2011 and 2015, more restrictive laws were passed than in the 30 years prior. They have trap laws, a 72-hour waiting period, a prohibition on the use of telemedicine to provide medication abortion services, mandatory parental consent for minors seeking abortion care. And their legislature really is enabling anti-choice organizations. So with their funding crisis pregnancy centers at huge amounts. And although they did not have a trigger law in North Carolina, they really have just the governor is able to veto tremendous amounts of anti-choice law that comes to him. And so that is a very precarious situation, because if that seat is lost, then this will all very, very quickly shift in North Carolina. In Wisconsin, during the Walker administration, Wisconsin passed a series of laws and regulations targeting abortion providers. There's a 20-week abortion ban, laws mandating an ultrasound and a 24-hour waiting period. When we did our research, there were only 4 abortion providers in Wisconsin, and all of them are in the southeastern part of the state. And now there is a criminalization law that will go into effect post the overturning of Roe v. Wade. And really, everyone in Wisconsin just said the word that they used to describe it was a tinderbox, right? Like it's waiting to reproductive rights in general are essentially waiting to just blow up in Wisconsin. And really what everybody talked about is the effect that this has, and I think this is what we all care about most deeply, is the greatest on the most vulnerable populations, right? And so each of these things is attacking the same groups of people, which I think is what Dr. Hall and Dr. Samari are going to get into in greater detail. So just to close, I'll say in these 3 states, in Maine, they talked a lot about how even in a state where Roe is codified into law, there are ripple effects, right? So an uptick in anti-choice legislation is still possible on the state level. There's future elections. For example, the 2022 election in Maine is coming up, and if it goes Republican, the sort of progress that they were able to make in Maine can quickly be erased. And they also talked about how there's threats that undermine the mental health and well-being of patients. There's a sowing of fear and uncertainty, even in a state where abortion law is protected. In North Carolina, I mentioned the Democratic governor is really the last line of defense to further restrict abortion. It's quite possible with gerrymandering that the legislature can overturn that veto very shortly. There's no trigger law, but again, the state legislature will probably do everything they can to change that soon. And they're also, Terry mentioned this before, but bracing for an increased caseload from neighboring states. So they really see themselves as becoming a safe haven for South Carolina, for Georgia, for Texas, for Tennessee, and organizations voiced over and over again their worry about capacity and will they be stretched too thin? They could risk prosecution. So again, these things are all connected. And then in Wisconsin, the hostility toward reproductive rights, I think, was the most clear with the trigger law, with the criminalization, which Goleen will address shortly. And then the last thing I'll say is that contraception in general could be sort of on the chopping block next, right? So I think that was made pretty clear in the decision. So it said the right Roe and Casey recognized does not stand alone. To the contrary, the court has linked it for decades to other settled freedoms involving bodily integrity, familial relationships, and procreation. Most obviously, the right to terminate a pregnancy arose straight out of the right to purchase and use contraception. In turn, those rights led more recently to rights of same-sex intimacy and marriage. So again, all of these things are interconnected and all of them are really something that we have to continue to fight for. So I will turn it over to Dr. Hall.
Great, thank you.
Yeah.
Hi, everybody. Thanks so much for joining us today. It's a real pleasure to be here with you. So I want to start by sharing a few things from a research program that I led before I rejoined POP-FAM in Columbia in March 2020. So I worked with this amazing team at Emory that was called the Center for Reproductive Health Research in the Southeast. And the center was really designed, impetus to build a center, in fact, was really to study the impact of policy, including restrictive abortion laws, on a whole range of outcomes across the Southeast region. So much of what you heard Dr. Grilo share and Professor McGovern, we were really designed to interrogate that in a pre-Roe era, right? And so what Stephanie has said is true, is that many states that were already in really restrictive climates have been gearing up for this moment for a very long time. And so we were really setting out to conduct some really rigorous research and policy evaluation on the effect of a whole multitude of policies. And so we also were looking at Title X, we were looking at the funding of crisis pregnancy centers, on a host of outcomes, both systems level outcomes as well as patient level outcomes. But one study I wanted to talk about a little today and give you some updated findings was around Georgia's abortion ban. So Georgia, when I got there, had already implemented a 22-week abortion ban. So it was 2 weeks past fertilization, or 20 to 22 weeks is what they would call it. And we study the impact on that first step. That was the first step in Georgia's legislature, right, toward a restricting of all abortion. And so we get to examine the disparities and trends in access to care for patients who were receiving abortions in Georgia because of that ban. So like we've already know, we saw a dramatic decline in later term abortion. So this was a later term abortion law, right? And that policy impacted disproportionately Black people, people living in poverty, lower educated people, et cetera. And so just really perpetuated disparities. And it not only impacted Georgia, but also the residents that were coming from out of state, because at that time, Georgia and Atlanta was really a safe haven for the Southeast, where Alabama, Mississippi, some of the surrounding states had already experienced even more severe policy climates. And so we were able to use those findings and a multitude of findings from my team in the courts whenever Georgia legislators put forth a 6-week, the heartbeat bill, they called it, right? And this was HB 481. And so this was in 2019. And so that bill went up before the legislator, and my team got to serve as expert testimony and present our findings to the court. At that time, many of the reproductive justice organizations, the community partners that we work so closely with, fought the fight. Stacey Abrams was gunning for office, and it was a real showing of what we can do to combat these policies, because as Professor McGovern mentioned, everybody's been on the defensive for so long, and now we're even more on the defensive, but Georgia was always sort of on the defensive. And so we were able to fight back, and that policy did not pass at that time. Fast forward to now and post Dobbs, and immediately Georgia passes the 6-week ban. And so that ban is now being implemented. And what we have seen, so my team, who's still leading some of this work there, we have a new paper that we're submitting actually this week that's looking at projections of what's going to happen in Georgia now that the 6-week ban is passed. And so what we find is, again, not surprising, overwhelmingly early term abortions represent the majority of abortions. So with this policy going into effect, it will eliminate access for 2/3 of abortions that are happening in Georgia and surrounding states. And again, the rates are much worse for Black people, lower educated people, and younger people too. So it's a very, very dire landscape, right? And as the other two panelists mentioned, these have really ominous implications for maternal mortality in states like Georgia, as well as across the country. I mean, Georgia is the leader in maternal mortality. Rates of maternal mortality have been increasing for the past few decades in the United States. And so one of the studies that one of actually Goleen and I's colleagues, Amanda Stevenson, published in Demography recently was a simulation study looking at the impact on maternal mortality from a hypothetical total abortion ban. And as Terry mentioned, predicted a 21% increase overall, but 33% increase for Black people, and also a significantly different higher increase for Hispanic people. And so these policies in states like North Carolina, in states like Alabama, Louisiana, and Texas just compound the inequities in adverse maternal and child health outcomes. We see the same kinds of trends for infant morbidity and mortality, so higher rates of stillbirth, higher rates of preterm birth, and higher rates of infant mortality. One of my postdocs, Dr. Sarah Redd, who's now going to be a professor, I got to mentor her dissertation that was focused on looking across the whole United States and creating an index of restrictive policies. And so it's really about the whole policy climate. As Dr. Grilo mentioned, these policies don't operate in isolation, right? And so we were able to look at the compounding effects of multiple policies, including mandatory waiting periods, including ultrasounds, including medication abortion laws, which she really dove into in her dissertation. And so we saw, again, across the board, adverse outcomes on infant, adverse effects on infant outcomes. And those were significantly worse in terms of geospatial trends in the most recent years when the hostile climate has really risen, as well as in the states where the disparities are just really profound and there's no safety net. I'll talk more about that in just a second. And there was another recent study by my colleagues in Georgia that were looking at what happens if the policy in Georgia goes into effect, and at the individual level, what are patients going to do? They're going to continue to find ways to have their abortion. Some of them are not, because they're not going to be able to travel and have resources to access abortion in other states, but some of them will turn to illegal and unsafe methods, just in a pre-Roe era that we saw in our nation's history, as well as in other developing contexts. So this study, they looked at 382 participants, and almost all of them, 85%, considered at least one way to end a pregnancy if abortion were legal in their states. So again, not really a surprise, but having data to support these types of studies will be used in the courts, hopefully. And of course, that comes with a whole range of negative emotional effects and negative mental health and social effects for the pregnant and birthing people and their families and their communities. So we see maternal mortality not just from unsafe abortion alone, but we also see these laws as they impact pregnancy complications and medically complex pregnancies, all of which contribute to severe maternal morbidity and the major drivers of maternal mortality. And so, for instance, having a law that restricts abortion access has ripple effects on the whole healthcare landscape. So the same treatments that we have for induced abortion, particularly early term, are the same treatments that we use for miscarriage management and for ectopic pregnancies, and for cases where the mother is at risk of dying because of sepsis or obstetric hemorrhage or hypertensive disorders of pregnancy. And so for this goes even pre-pregnancy, right? So this goes into the preconception period where people with chronic conditions may have higher risk of these adverse outcomes. Again, disproportionately among Black people, lower income people, et cetera, because of structural reasons. And so when you remove induced abortion as a treatment option, then the life-threatening conditions only become more profound and severe. And so this really limits quality of care, patient-centered care, and the ability of providers to build trust with their patients and with their communities that they serve. So again, more disability and more deaths for mother and fetus. Further, the implications, there was an article, a really interesting article in the New England Journal recently about the implications for breast cancer treatment, right? So patients with breast cancer who become pregnant who are undergoing chemotherapy and some of the other treatment, I mean, it's gold standard treatment recommendations for cancer during pregnancy. Induced abortion is the treatment option. So for those patients, the effects are pretty profound. And the same is true for other chronic conditions, even things like rheumatoid arthritis, which is treated by a drug called methotrexate, retinoids for young women with acne, and the list goes on and on and on. There was another article in the New England Journal about the implications for emergency departments. What are emergency departments going to do in terms of ethical decision making? And so the article was titled, let me see if I can find this, that was very interesting. Supporting, not reporting, and ethical questions around how you care for, how you provide quality care. And so just a couple of quick comments on the health systems. We know a lot about the effects on the population level, on the effects of people and their families in terms of health effects. But also one of the things that my team at Emory really dove into was what does it mean for health systems and systems of governance and accountability? And so we studied things like how are anesthesia providers responding to Georgia's HB 481? Like, what does it mean to be an anesthesia provider? We studied the impact of nurses and clinical decision-making in the nursing sector. The same thing is true for maternal fetal medicine and neonatal. It's a complex, intricate healthcare system, and you can't have such a profound policy that doesn't impact the whole system. I know we're going to talk more about criminalization in just a second, but just a quick comment on if we think about reproductive justice as spanning the whole continuum of reproductive rights and what it means to be a parent or not be a parent or want to give birth or not give birth. We think about infertility and the impacts on IVF and frozen embryos and the grayness. You know, when we say post-Roe and we say overturning of Roe, there's a black and white connotation around some of this. There's so much gray around decision making by policymakers, by people interpreting those policies, the ways in which the policies are implemented or not. So one of the things we learned with my RISE Center, we looked at how a whole host of stakeholders were responding to Georgia's 22-week abortion ban. And so how did clinics respond? How did family planning clinics respond? And they're really resilient. What we learned is they're actually really resilient at trying to support patients' care. The same thing is true for things like abortion funds and community-based organizations, including some of my Title X partners who were running FQHCs and trying to figure out, okay, Georgia's got this really restrictive climate. How do we assure patients' care, knowing that we're here to fight that fight? And so we learned about that. And as scientists, and I know we're not talking too much about methodology here today or how we even try to conduct this research, but as scientists, that becomes gray for us. How do we report findings that could be incriminating to providers? But these are lessons learned that could really change the landscape on how we respond. So it's extremely complicated. We led a panel at the Society for Adolescent Medicine a couple of years ago with a bunch of lawyering organizations, actually IFWIN now and some others, to think about like, how do we form multi-sector partnerships as academic researchers, as public health professionals, as policymakers? to try to figure this out, because at the end of the day, we don't want to harm our patients further by the data we're collecting. We really want to support best practices. And then there's whole implications for substance use pregnancy, which we'll probably hear more about in terms of criminalization, and I can share more about from my interest in integrated care. Finally, I just want to comment profound socioeconomic effects, right? So there's a whole body of literature out there to look at the ways in which access to reproductive health and reproductive autonomy and reproductive justice is associated with economic security and economic well-being. And so as Terry mentioned, in the states with the most restrictive laws around abortion, those are the same states that don't have the social safety net, that don't have the economic laws, that don't have things like minimum wage and TANF and EITC laws, paid leave. So one of my projects is going to look at these laws in regards to maternal mental health and morbidity and mortality. Same thing with Medicaid expansion and childcare support laws. We know from the Turnaway study that those people who are denied a wanted abortion are more likely to be unemployed and have low life aspirations in the short term, and in 5 years more likely to be living in poverty. So again, structural inequities that have implications for patients and providers and communities. And so I think I'll stop there and turn it over to Dr. Samari to talk more about her work in immigration and criminalization.
Sure. Thank you, everyone. We've covered a lot, so I'll try to be really brief to leave time for questions and comments and interaction. As Professor McGovern mentioned, I do a lot of work at the intersection of racialized groups and reproductive health. So racialized groups include groups that are minoritized and marginalized on the basis of things like race, ethnicity, religion, and immigration status. So when I think about abortion criminalization, I approach this from a space of these groups are already marginalized and minoritized, and then you're layering in abortion criminalization on a host of other structural inequities that are already affecting people's lives. And so I think that orientation is really important, because it's not for me the impact of a particular abortion restriction or abortion criminalization policy on an outcome. It's about how that policy interacts with all these other factors that are affecting people's lives and how that ultimately shapes the outcomes. So I'm going to talk a little bit about 3 different pieces of work that are of relevance to this discussion. The first I want to draw your attention to is this piece that's going to be coming out later this month in the American Journal of Public Health, led by 2 incredible doctoral students at the University of Washington, Taylor Riley and Yas Zia. And they approached me and were really interested in writing a piece about how abortion criminalization really extends this legacy of white supremacy and reproductive control as of pregnant persons racialized as Black. So I think that piece is going to be essential reading for a lot of folks. We start off that piece really centering reproductive justice and Loretta Ross's definition of reproductive justice, one of the founders of the movement, which is really that you don't isolate abortion from other social justice issues like that affect communities of color, including economic justice, the environment, immigrant rights, disability rights, discrimination on the basis of race and sexual orientation, and a host of other community-centered concerns. So again, I explain that's sort of my orientation to my work overall. But I think the history of knowing that abortion criminalization, especially in this country, has been really tied back through white supremacy from the forced reproduction of women who are enslaved after 1808, basically, when slaveholders could no longer rely on international slave trade. The expansion and sustaining of slavery required reproduction of those already enslaved. And so some of the earliest US laws are really based in control over enslaved women's reproduction. So I think when we think about criminalization today, we really have to hold that history really centrally, because our laws just built on those laws and they didn't go away. They just continued to expand, take shape, and new forms, but essentially the same mission, in my opinion, which is to control the reproduction of people and communities that are racialized. The original criminalization laws, like I've said, really are about ensuring that the United States remains a white nation at the end of the day. And the public health effects are really vast. We've talked a lot about the public health effects, so I won't get too far into that, but we estimate about 1,200 people have been arrested because of pregnancy outcomes since 1973 when Roe was decided. So that's while Roe was the law of the land. Abortion bans not only restrict access to essential health care, but they have destructive implications across the life course and wide-reaching impacts on families and communities because of the way that they intersect with economic and health consequences. So I encourage you all to read that piece when it comes out. I'm really proud of the doctoral students that led that work, and I think it's an important piece to read if you're interested in abortion research and criminalization or just policy in general. A second piece of work I want to just touch on briefly is work that I've had the privilege of collaborating with some folks from IFWEN, Lawyering for Reproductive Justice. They're leading work that really looks at criminalization of self-managed abortion from 2000 to 2020. So Laura Huss and Farah Diaz-Tello came to me and said, you know, we have identified all these cases of people who were criminally investigated or arrested for allegedly ending their own pregnancy or helping somebody to do so. And there's 61 cases that they uncovered across all 50 states. Most of these cases emerged from Texas, Ohio, Arkansas, South Carolina, and Virginia. Most of the cases involve adults. About 74% of the cases are adult cases, or the person themselves for self-managing their own abortion. So self-managed abortion generally refers to taking medication abortion, but it can include a whole host of other mechanisms for self-managing an abortion. People use a variety of methods in this sample to self-manage. Majority is 52% is medication abortion. None of the other methods really had above 10%, but there's things like, you know, other household toxins or physical force and other things, as you can imagine. Gestational age was mentioned in 87% of the cases, and the majority of the criminalized self-managed abortion cases occurred in the second or third trimester. 11% involved minors. I think it's important to remember that we haven't talked a lot about it today, but it is a huge aspect of the work that we do in this department, which is the sexual reproductive health of adolescents. And so those are groups that are also left out and often bear the biggest burden of abortion criminalization and bans. Let's see. So the people of color, as you would expect, are disproportionately represented when you compare the sample of cases to the larger population. We have about 41% minoritized racial and ethnic groups in the sample. And I think the part that's really difficult and disheartening and kind of links back to what Professor McGovern was talking about, a lot of the cases came to the attention of law enforcement, most often by care professionals who are designated mandatory reporters. So healthcare providers and social workers. Now let that sink in. You went to seek an abortion from your healthcare provider or your social worker because of your life circumstances, and then they were designated mandatory reporters and you were criminalized for that attempt while Roe was the law of the land. So these cases are all from 2000 to 2020. That's important because it gives us a glimpse of now that Roe has fallen, which was clearly not a ceiling, of very much a baseline, what is to come. And that's really sad and scary. And we really need to be watching the space and who's a mandatory reporter. And providers that we've spoken to, and Dr. Hall really spoke about this as well, are very conscious about, you know, what can they do and what do they have to say and what does the law say, and really reading between the lines to figure out in these states where abortion has been banned, what can they do and what can they not do for their patients. I think the 39% of the cases were reported by healthcare providers. That's a lot. And the cases really paint a picture of the legal landscape ahead and what potential landmines will exist for abortion seekers. I think it's also important to point out that we kind of casually mentioned criminalization, but criminalization puts people into like a carceral system that we can have a whole week's worth of seminars on, has its own set of issues. And so it's not just like, oh, sad, people were criminalized. It's that it introduces this whole system and stigma and lifelong burden for somebody who sought after an abortion. That's an added dimension to their entire life, to their family's life, to their community's life. It changes their life forever. And so I think we really need to speak of it with that seriousness and really hold that in our conscious. The last piece of research I want to talk about is that I had the privilege of leading some work that really focused on the immigrant community in the New York area during the pandemic. And why this is important is because immigrants were already under a whole host of structural constraints during the pandemic, not being able to access relief funds, for example, being disproportionately frontline workers. And my work really focused on immigrant voices and experiences and trying to seek out sexual and reproductive health care in that type of policy environment that's really restricting and not providing any economic relief. And I think that work can provide a glimpse as to what those communities will continue to experience as you layer abortion legality on top of that. I think one quote really kind of captures the immigrant experience, particularly in New York during the pandemic, during the height of the pandemic. So I'm going to go ahead and read that quote for you. We got the delivery guys, the house cleaners, all those people that were somewhat hidden and unseen before COVID were thrust to the front of the pack because they were the ones who kept the city going. They kept us all going, which meant that they were the most at risk, which then translated to being the group of people that by and large as the majority of deaths when it came to COVID, right? So it's all of those things mixed together. Their reproductive health needs kind of drop down the list of priorities because there's other things happening at the same time. So I think a lot of times we, when we think about reproductive health and sexual health, we think it's at the forefront of people's minds, but there's whole lives happening in the background. And when those whole lives are really limited by structural constraints or racism or structural racism, reproductive health isn't always the top of mind. And so then when you reduce access to reproductive health on top of that, you can imagine who is experiencing the most suffering. A lot of the providers that we interviewed for that study reported that there wasn't a decline in access to abortion during that time for immigrant communities, but there was a shift to later term abortion. So maybe you wanted an abortion at 6 weeks, but you weren't able to actually get it until 10 weeks. And that's in New York where abortion access is protected. So with that, I will leave it because I know we have a lot to discuss, but
Okay.
happy to answer any questions.
Thank you. Thank you. Okay, we'll start to take some questions. And I also have some questions for the panelists. So let's begin with there's one online, which I feel like I'm looking at John, but he's eating. Sex education, preventing unwanted pregnancy. Isn't there a large percentage of women and girls who haven't had access to sex education, who need abortions? Like what's the linkage between the lack of sex education and abortion?
Well, I mean, there's a host of studies that suggest that sex education, of course, changes the behaviors that lead to pregnancy.
Okay.
Comprehensive sex ed even helps some young people delay initiation, but they certainly, the evidence is pretty incontrovertible that sex education supports contraceptive use. You need to know about it. You can use it.
Thanks,
It's
John.
common sense. And it probably prevents abortion because it prevents people from getting pregnant. But then we're getting to the edge of the science here. But yeah, so I mean, the same groups that are attacking abortion, the same social forces, also don't want us to have sex.
Right. Okay.
So I mean, they have a belief system should be said that supports that. But, it's not supported by the demographic program evaluation. So.
Thank you,
And
John.
I would just add the same states that have the least comprehensive sex education policies, the same states that have the most restrictive abortion policies.
Right.
And the worst outcome, maternal health outcome.
Yeah. Okay, yes.
Yeah, so what's sort of has been coming to mind lately is where there should be kind of clinical clarity as to where it is a threat to the life of the mother or a threat to her health. It's a morass, right? We're getting reports of just hours of, clinicians consulting this medical experts, and I don't quite understand why there's such a disconnect. Like, I know the ACLU has, there should be more coordination. Why isn't there? And is there an advantage to it remaining easy? Like, I don't know. Does that help?
So, I mean,
So you mean that, so for instance, in Georgia's first law, the 22-week ban, right? So and Larry's, or not Larry, Terry is much more astute. I was gonna say Terry's the legal expert in terms of the language in some of these policies, but it's not written as black or white. There's like a whole tiered effect of if this, then this, then this. And like, so when we looked at our 22-week ban study, we actually surveyed providers to see what they knew and understood about the law. Nothing. To trying to interpret the law, we went through a bunch of hypothetical scenarios around how would you treat the law in this particular scenario if there was a fetal anomaly, and it's very complicated for providers to make sense of that, especially in real-time circumstances when the mother's at risk, right, for imminent death or disease.
I guess what I would think is that there are many clinical guidelines for so many things,
Yep.
right, that are posted on the wall, on the ER, and, you look and you say, okay, this is happening, well, let's do that.
Yeah.
I don't really
So-
understand why we don't.
One thing I'll just say one quick thing that I wanted to make a point about earlier. Whenever Georgia's 6-week abortion ban started taking place just recently, my colleagues at Emory, which is more the progressive institution in the whole state, right, seeing a lot of family planning patients, stayed up the whole weekend overnight around the clock rewriting their entire obstetric policies and regulations for their department, the massive overhaul. And what does that mean for providers who are trying to figure out how to provide care on a day-to-day basis? So
yeah, so I mean, that's honestly, all kidding aside, since Roe was overturned, people who have legal expertise and public health expertise, I mean, the legal questions are just enormous, right? And we have no adults anymore. Like, if things go to the Supreme Court level, right? So it's changed the landscape so dramatically. So your question is a good one. I mean, first of all, I can't tell you how many colleges have called to say, what do we do? We're in Ohio. The issues of very good people not wanting to lose their licenses, being at risk, are severe. The issues of what are the procedural protections around medical records are huge. What providers write down, what providers do, can they be subpoenaed? So this has unleashed like just huge, enormous questions, including the ones that were discussed in that Times article about hospitals in states where abortion is outlawed or criminalized, figuring out procedures for ectopic pregnancies, procedures for all the things that you described. It's an incredibly gray area, and the answer to does it help to write things down? Does it help? It's complicated, right? And so, it has really unleashed enormous amounts of complexity and pressure, which is really taking away from providing care to people. And I just like to remember to keep saying that banning abortion, criminalizing abortion does not decrease abortion. So what are we doing? But a very good question. And, this is unfolding and iterative over time, right? So the answer of leaving things some gray, a bit gray, that might be the answer, but in some places, yes, in some places, no. Procedural protections around medical records are critical, right? But there's state law, there's federal law. So,
Mary, can I add one thing?
please.
I think what came to mind when you asked the question too, I've heard countless stories already of the pause between a provider knowing what they have to do or knowing what they should clinically do and pausing because they're like, I don't know if I can do this. And then they have to wait go get legal advice from their hospital's general counsel about what they can do, what they're allowed to do, what they're not allowed to do, and then returning to the patient's bedside where things have now completely changed because that pause is critical in the person's health. And so just the fact that it's shocking to me still that we would ever get in the way between someone who is trained clinically to do what they need to do, and then making that pause is going to create an enormous burden on people's well-being and health.
So go ahead.
So not even does that pause happen in real time with the patient and provider there in the most restrictive state, but it also happens in the states that's even threatening ban, right? So we saw in Georgia, for instance, that even just the threat of introducing a ban changes provider behavior and changes fear of litigation. And we're seeing the implications of that happen even in safe haven states like New York, in Massachusetts, and Boston, and Maryland, where in terms of like social workers and mandated reporters, already starting to have conversations around, what do I do with this patient who uses substances and needs an abortion, right? And is coming to me in a state like New York, which has really protective laws. And so we're seeing already an influx in Planned Parenthood, Greater New York, as well as Planned Parenthood League of Massachusetts. And the grayness is starting to infiltrate these other places too.
I mean,
So-
and along those lines, the global gag, or
Yeah.
the global
Yeah.
gag rule, all that over interpretation,
Mhm.
just sort of made it worse,
Mhm.
right?
So I'm going to call on you in the back, but let me just say that I guess the online people aren't hearing the question. So that question was about how are providers to respond to this? Is it better to leave some areas gray, or is there a whole new policy? So this is what this whole discussion has been about. And then we have some other online questions, but let's go to you next. No. Yeah.
Oh, I just want to touch comment on the, you gave a percentage, Dr. Samari, like 39% of healthcare providers are the ones are reporting. So I worked on a unit where we did provide abortion care. And it was interesting before our hospital took on that role, because we were one of only 2 hospitals that provided abortion care. The other ones were religious affiliated. And so 1/3 of our nurses opted out not to provide care to those patients.
Wow.
And so that was
Wow.
really interesting, coming from a place like it was Portland, Oregon, where it's a lot more progressive than a lot of other states. So it's going to be really interesting to see how that plays out in states in the South.
I think that's a really important point. I think there's quite a bit of research on religious affiliated hospitals and and abortion access and things like that. So that's a vast body of research that I think is really important. The statistic, just to clarify, that I shared was amongst the cases that we know were criminalized.
Oh, right, yeah.
39% of the cases came to the attention of law enforcement through healthcare providers. But the percentage of providers who are opting out of care and the percentage of advanced practice providers like nurses and otherwise opting out of care is also very relevant and important to consider.
Are there numbers for that?
I'm sure
There are studies, and organizations like the National Nurses Association for Sexual and Reproductive Health are really working around this to sort of change the tide in the nursing community that in some states has been more historically conservative and has huge positions of power in policymaking bodies at the state levels. Like for instance, Georgia, the nursing board was a prominent player there. So
Dr. Garden.
Thanks for this. Mikal, is that you? I can't see it. Is that you, Mikal?
Yeah.
So I thought it would be helpful, and I don't know whether Dr. Samari, Professor McGovern wants to talk about this, but this really seems to be what was touched on, is that the department's already done a fair amount of research into the idea of like chilling effects, right? So with the public charge or with the global gag rule, that when these rules are put into place, part of the negative effect is that people will avoid providing certain services to avoid losing funding, or citizens will avoid, or individuals in the community will avoid seeking needed services because of fear of retribution. And some of these laws actually work in this way, right? Intending. So I don't know whether any of you wanted to talk about the work that you've done on really quantifying what the chilling effect is, and how we all have learned from that.
Yeah, so my immigration work and the study that I briefly touched on, so 44 of the interviews were with cisgender immigrant women in the New York area, and I would say majority of them reported avoiding seeking reproductive health care for a variety of reasons, including that they lacked documentation and didn't, or things like, which is a chilling effect in essence, or they had experienced racism in a clinical setting or in another interpersonal environment and didn't want to seek care because of that, or because of all of the things that went on with the public charge rule, the language being changed and it becoming more punitive and then it being rolled back. I mean, that type of thing, like it was mentioned, I believe Dr. Grilo mentioned it. You can't just implement a policy, take it back, implement it, take it back, adjust it, make it more harsh, make it more lenient, and then say, go community. Who knows what that means, And so we really need community-based resources, community-based advocates, messaging that comes from within these communities, because otherwise it's just not getting to them. And that's why a huge foundation of public health work and getting people into care and preventative health care is really community centered and in partnership with community, because that is one way that you combat things like a chilling effect of all these policies.
We have a whole special edition of Reproductive Health Matters on our global gag rule research, which is very much about chilling impacts and how unleashing this kind of thing just creates chaos, and the impacts are huge. So if anybody's interested, you can find it. It was from a couple of years ago. I wanted to switch to a kind of important issue that I was going to ask about, but I see Professor Flynn has already also asked. Okay, so we had some good news, right, out of Kansas, right? That referendum, 59% Republican state, I believe the numbers, or something, very white state that voted to preserve protection for abortion. We have a Michigan referendum coming up. What are your thoughts on the electorate and the possibility, the potential for some surprises related to the overturning of Roe? Pessimistic, optimistic? We're seeing some shifts in voting. Yeah. We certainly did in Kansas. So just wondering what we think about that, given the gerrymandering, the suppression of voting that we know. Is there cause to be hopeful?
I mean, I'll start. I think so. After that, what happened in Kansas, I was on the way into the office and listening to NPR, and they were talking about the newest Pew data, for the statistics on Americans who support abortion, and it's going up. It's actually going up for the first time in decades, right? It's been rock stable, and it was already high in terms of support for abortion. And I could not agree more with what you said, Goleen, around community-driven approaches and community-centered approaches. And this is where all of your work, Professor McGovern, around advocacy and really organized, community organizing. We saw that play out in Georgia, and that's part of why Georgia had fought the fight for so long and been successful in holding back so much policy over all of these years. Organizations like Sister Love and Sister Song, who I had the pleasure of working with and who I know Terry does too, we led a study that we jointly led a community-led study actually that looked at medication abortion access and the intersectional barriers that women faced in terms of transportation and racism, and the solutions. We had a whole section in our interview guide around solutions and strategies. And so Atlanta, is the home of reproductive justice, the birthplace of reproductive justice, and organizations like Abortion Funds, who I know you work with in Wisconsin, as well as the policy and advocacy organizations who have built really strong relationships with the policy makers
they're changing the tide. It's slow. It's been a slow go and a constant reactive stance, but they almost had a comprehensive bill passed before I left that had a whole host of really proactive positive measures. And so I think Kansas is a super interesting case study. I don't know if anyone is studying it at the moment, but I think that there's hope.
Anybody else want to add?
I'm cautiously.
I was gonna say, I'm more
I don't know if I'm at hope yet, but I'm keeping an eye on it. Yeah.
I think I'm just like, I think the power behind restricting the vote is what keeps me pessimistic.
Yeah.
Like people are working so hard to ensure that it's harder to vote, that you can't vote early, that you have to vote in person, that you have to vote between these times where people have 3 jobs. Like, how are they going to get there in time? And who does that hurt, right? Like it hurts the communities that would support.
If you think
we're all talking
voting
about.
rights are separate from
Yeah.
reproductive justice, then you've like missed the whole picture.
It's how they keep power.
Yeah.
Okay, so I there's a couple of more questions here. One is, which besides voting and protests, what can we do? Another is, does anyone have thoughts on how we can counter the right-wing populist or conservative framing around abortion as murder? Because our public health messaging takes too much time. How do we simplify? These are really hard questions.
Yeah.
I'll ask you each to take a step or whoever wants to respond, and then I'm going to come back to close on reasons for optimism, because having just given a climate change lecture, we need some reasons for optimism. So,
Around public health messaging, I think that's a really interesting question. There's some really great work coming out of a professor who's now at Indiana, Kristen Jakowski, and she was formerly in Kansas, actually. Kansas, I think Arkansas, sorry. And they are looking at the multidimensionality of abortion attitudes and how that shapes abortion behavior, including things like voting. So you also check out some of that work. It's really complicated. And so I think there is Planned Parenthood. There's been a lot of organizations out there really trying to change the tide around messaging and public paradigm. And I think the importance of front and center lay perspectives and qualitative perspectives and testimony of experiences partnered with science to an evidence or to a policymaker more than science is evidence, right? And so changing the whole paradigm. But that work is really interesting. Kristen Jakowski.
thank you. Okay, so we have like 6 minutes left. So I'll just ask each of you to kind of talk about both what can people do and if there's reason for at any points of light in this whole conversation. Goleen, let's start with you.
Oh, gosh.
Sorry.
No, it's fine. I think that it's been a really interesting and dark set of years with the pandemic and ongoing pandemic and everything that we've sort of experienced. And the pieces that kind of stand out to me as points of optimism are the way that community organizations have really come together as coalitions. They really go beyond their sort of missions. In a lot of community organizations, for example, that I spoke to for my work that's very New York based, we're focused on certain aspects of like immigration law or gender-based violence, and they quickly became comprehensive sort of CBOs trying to connect women and men to sexual reproductive health resources, trying to make sure there was ongoing access to contraception. And I just think that the way people mobilized, the way that they connected to one another and really came together in coalition building offers a point or a sort of bright light as like a way forward. And so how can we better resource those organizations? How can we change policy that really enables them to continue to impact their communities in the way that they have?
Yeah, I couldn't agree more. I was going to say something similar. You know, one of the things we've thought a lot about this past year in developing Mailman's new Office for Community Partnerships and Health Equity is using our power and privilege and positionality here as an anchor institution. And that can apply nationally as well, not even just locally, to really support communities and community organizations in doing this work. And I think that that's true for multi-sector partnership building as well. So in terms of getting engaged and support and helping build capacity to address some of these things is really important.
Yeah, I mean, I would agree. I think what an exciting thing about PopFam is the way that many of us do research is by not just doing sort of research for research sake, but doing it like to really partner with and help like on the ground grassroots organizations. I think that was the exciting thing about the Title X work. So getting involved in work like that, I think, is really important. And then back to our other conversation, I think these things aren't separate. So voting, getting out the vote, and figuring out how to push back against, you know, gerrymandering and restricting the vote, I think, is really critical moving forward.
Yeah, so I mean, I would say I want to have an announcement from somebody in the chat that I want to make, but I think, first of all, in my long life, many of us have long been kind of saying the things, obviously the reproductive justice movement, that we cannot talk about abortion and not talk about these states doing nothing to protect the health of women and children, doing nothing to what's actually going on in the foster care systems in these states like Mississippi, where children are dying of starvation. That if we do not link abortion and reproductive health to the rest of these issues, we're not going to win. We saw that's what wins in other places. So I have to say, it is gratifying to me that the New York Times and other papers are now constantly writing about things we've known forever in public health, that these states are, that the hypocrisy levels here are so extreme, right? So that's really hopeful to me. I've seen a shift. A bunch of us are working on a paper for UNFPA. How can we take a reproductive justice approach to global governance around reproductive health, which means for real. Why aren't we counting people under 15? Where are Indigenous people in the data? You know, I see more movement around these issues than I ever have in my life. And I'm sorry to say that it's because of the hideousness which has been unleashed, but there are points of light. I find a lot of points of light, not only in the community groups all around the country, the people, the amazing people who are rising to this challenge and will not stop. And I see it in all of you, right? We are not just going to sit idly by and watch them kill people. So that is, it's tremendously inspiring to me to see how people are behaving. And I also have to say, I have some hope that some of those white women who voted for Trump are going to vote differently because of paying attention to what's happening around abortion. We're seeing some shift in those numbers, which is promising for a lot of issues. Let's hope there's been some kind of a breakthrough here. So lots of reason for optimism and lots and lots of work to do in every lane here. So please do get involved in whatever way. And I just wanted to share, I can't open my phone, but there is a very important convening coming up by one of our partners in Wisconsin, which they asked us to announce to you.
Yes, the 14th annual virtual Black Women's Wellness Day. So it is going to be, we can send this out to the PopFam list. It's like Friday, the last Friday and Saturday, I believe, of September. And they have some great panelists. So the president of the Black Women's Health Imperative, the founding director of the Birthing Project USA, the co-founder and executive director of Black Women for Wellness, and then someone from the Black Mamas Matter Alliance. So we'll share that with all of you.
Anyway, yes.
Could you also send out the article when it comes out in about a month on the PopFam server?
Sure.
I'm very excited.
Sure. Yes.
PopFam grad.
Nice.
Great.
Okay, thanks everybody.
Thank you.